The heart sounds. The heart sounds are relatively brief, discrete auditory vibrations that are characterized by intensity, that is loudness, frequency, pitch and quality timbre. Sudden deceleration of the blood within the cardiovascular system produces the heart sounds. The rapid deceleration of blood initiates vibrations of the cardiac structures immediately after the coaptation of the valves that produces first heart sound and second heart sound, while the rapid deceleration of blood in the ventricular inflow producing the vibrations of the cardiovascular structures appear to be responsible for the production of third heart sound and fourth heart sound. Basically, the heart sounds are of two types: high frequency transients due to closing and opening of the valves, low frequency sounds that are related to early and late diastolic filling events of the ventricles. The figure shows basic heart sound, first heart sound, second heart sound, third heart sound and fourth heart sound. Now, high frequency sounds due to opening of the atrioventricular valves are sounds due to opening of the atrioventricular valves, that is opening snaps, mitral and tricuspid non-ejection sounds. Sounds related to closure of the atrioventricular valves, first heart sound, mitral and tricuspid closing sounds M1 T1 are mixed frequency sounds. High frequency sounds due to closing and opening of the semilunar valves are sounds related to closure of the semilunar valves, second heart sound, aortic and pulmonary closure sounds A2 and P2. Sounds related to opening of the semilunar valves, early valvular ejection sounds or clicks that are high frequency sounds. Now, low frequency sounds related to diastolic filling of the ventricles are physiological and pathological third heart sound, which is associated with early ventricular filling events. So, third heart sound is a low frequency sound. Presystolic atrial gallop. Presystolic atrial gallop S4 associated with late diastolic filling events. Summation gallop due to merging of S3 and S4. Synchronous occurrence of S3 and S4 as occurs in tachycardia. Other heart sounds include pericardial knock and rubs, tumor plops, that is in atrial myxoma, prosthetic valvular sounds. Depending upon the cardiac cycle, the heart sounds are also classified into diastolic sounds, early diastolic sounds, that is opening snaps, tumor plops, pericardial knock, opening sounds of prosthetic valves, mid diastolic sounds, that is S3, late diastolic sounds S4, systolic sounds, early systolic sounds, aortic and pulmonary ejection sounds, closing sounds of prosthetic valves. Mid to late systolic sounds, non-ejection sounds or clicks. Now, the first heart sounds. The first heart sound signals the onset of left ventricular contraction and consists of two major audible components M1 and T1 and two inaudible components. Now, this table shows characteristics of first heart sound. The frequency is medium to high, duration 0.14 second, M1 T1 interval 20 to 30 millisecond. C point of my MB echocardiogram coincides with M1. Downstroke of C wave of LA pressure coincides with M1. Downstroke of C wave of RA pressure coincides with T1. This figure shows characteristics of first heart sound, phonocardiogram and LV LA pressures. M1 coincides with the downstroke of C wave of the LA pressure. The first inaudible low frequency vibrations coincide with the beginning of the LV contraction and are muscular in origin. It is followed by high frequency audible M1 and T1 components, which are produced due to the closure of mitral and tricuspid valves, Dock's hypothesis and Latham. The last inaudible low frequency vibrations coincide with opening of the semilunar valves with ejection of blood into the aorta and pulmonary trunk. Now the characteristics of Firestar sound. S1 is typically medium to high frequency with an average duration of 0.14 second. M1 is followed by T1, which are separated by 20 to 30 milliseconds. Hence, in normal subjects, S1 is appreciated as a single sound, but split S1 can be recorded with a phonocardiogram. It is auscultated with diaphragm of the stethoscope timed simultaneously with the palpation of the carotid or cardiac apex. M1 coincides with C point of the mitral valve echocardiogram and downstroke of the left atrial C wave of LA pressure tracings, which is delayed from the LV LA pressure crossover by 30 milliseconds. Similar echocardiographic correlates are more difficult to demonstrate for T1 in the normal subjects, but T1 has shown to coincide with the downstroke of a RA C wave pressure tracing with greater delay between T1 and RB RA pressure crossover. Now, determinants of intensity of Firestar sound. Structural integrity of AV valve, thickness and mobility of the leaflets, velocity of the mitral valve closure, position of atrioventricular valve at the time of ventricular systole, status of ventricular contraction, isovolumic systole, myocardial contractility, heart rate, physical characteristics, vibrating structures, transmission characteristics, thoracic cavity and chest wall. Now, determinants of intensity of Firestar sound. The intensity of Firestar sound often gives clues to the diagnosis and degree of abnormality of the involved structures. The primary factors determining the intensity of Firestar sound are structural integrity of the AV valve, atrioventricular valve, that is thickness and mobility of the leaflets, velocity of the valve closure, position of the mitral valve at the onset of ventricular systole, status of ventricular contraction, the rate of rise of LV pressure, myocardial contractility and heart rate, physical characteristics of the vibrating structures, transmission characteristics of the thoracic cavity and chest wall. Now, the structural integrity of the mitral valve. The normal mitral valve has thin, pliable leaflets, which are capable of producing a normal Firestar sound. However, there is an inadequate coaptation of the mitral leaflets, causing attenuation of Firestar sound in the setting of severe MR. Also, the loss of leaflet tissue, as in infective endocarditis, attenuates the intensity of Firestar sound. A calcified mitral valve, as in long-standing MS, immobilizes the valve leaflets, which results in diminished or absent M1. Now, the velocity of the valve closure. It is one of the most important factors affecting the intensity of Firestar sound, which is determined by the position of the mitral valve at the onset of ventricular systole. The position of the mitral valve at the onset of ventricular systole is altered by relative timing of the atrial and ventricular systole, and 2. the rate of LV filling during atrial systole. PR intervals from 140 to 200 milliseconds usually result in a normal Firestar sound. So, PR intervals from 140 to 100 milliseconds usually result in a normal Firestar sound. At short PR interval 80 to 140 milliseconds, as in Parkinson-White and Lowen-Gannon-Leval syndrome, the mitral leaflets are maximally separated by the LA contraction. at the end diastole, due to which the MB closes at a high speed with a large excursion, which results in a loud and late M1. So, at short PR interval, as in WPW syndrome and LGL syndromes, the mitral leaflets are maximally separated by the LA contraction at end diastole, due to which the MB closes at a high speed with a large excursion, which results in loud and late M1. At longer PR intervals, more than 200 to 500 milliseconds, there is less separation of the mitral valve leaflets, which have already begun to close with atrial relaxation. Premature MB closure due to LV diastolic pressure exceeding LA pressure, and there is less excursion of the mitral valve with LV contraction, which occurs at lower LV pressure, which results in softer and early M1. However, when PR interval is more than 500 milliseconds, the mitral valve reopens and closes with rapid velocity, producing a loud Firestar sound. There is short PR, increased Firestar sound, normal PR, normal S1, long PR, soft S1. Relationship of intensity of S1 and PR interval. The rate of LV filling during atrial systole. When venous return is decreased in non-compliant hypertensive LV, there is more effective transportation of atrial volume into the relatively underfilled LV, resulting in widely separated mitral leaflets that produce a loud Firestar sound but soft and late S4. Increased venous return causes more vigorous atrial contraction, which results in less wide separation of the mitral leaflets at the onset of ventricular systole, producing a loud and early S4 but a softer S1. This is the most likely explanation of a soft Firestar sound in hypertensive patients with normal PR intervals. Now, status of ventricular contraction. It is also an independent factor affecting the intensity of Firestar sound. Ventricular contraction is affected by the rate of rise of LV pressure and heart rate. Increased myocardial contractility following causes increased myocardial contractility. This increases the rate of rise of LV pressure and thereby increases the velocity of the closing mitral leaflets. This further produces a loud Firestar sound. Exercise, hypoglycemia, thyrotoxicosis, pheochromocytoma, catecholamide infusion, high output status, anemia, pregnancy, AV fistula, fever, anxiety. In addition, high output status are associated with tachycardia that causes shortened PR interval and widely open valve due to the high flow through a shortened diastole, resulting in a loud Firestar sound. Similarly, a loud T1 in ASD is due to the high flow through the tricuspid valve secondary to left to right shunt at the atrial level. Decreased myocardial contractility results in decreased rate of rise of LV pressure, producing a soft Firestar sound, which may be found in acute myocardial infarction, cardiomyopathy, myocarditis, myxedema, ventricular aneurysm, drug-induced myocardial depression, in beta blocker, calcium channel blocker, disopinamide. Now, 3. Loss of isovolumic contraction results in decreased velocity of mitral valve closure, producing a muffling of Firestar sound, as in severe mitral regurgitation, severe aortic regurgitation, large ventricular septal defect, ventricular aneurysm. Heart rate. Tachycardia accentuates Firestar sound due to the shortening of PR interval, wide open valve as diastole is shortened, and increase in myocardial contractility as a result of staircase phenomenon, while bradycardia has the opposite effect. Physical characteristics of the vibrating structures. Alterations in the physical characteristics of the vibrating structures may also vary the intensity of Firestar sound. Pacing-induced myocardial infarction and ischemia have been shown to decrease the intensity of Firestar sound secondary to these alterations. Now, transmission characteristics of the thoracic cavity and chest wall. Higher frequency heart sounds are attenuated to a greater extent than the lower frequency sounds. So, higher frequency heart sounds are attenuated to a greater extent than the lower frequency sounds. Conditions such as obesity, emphysema, large pleural or pericardial effusions will decrease the intensity of all the auscultatory events, whereas a thin body habitus tends to increase the intensity of heart sounds and murmurs. Now, evaluation of Firestar sound. Increased intensity of Firestar sound, it occurs in mitral stenosis. Loud Firestar sound is due to the thickened but mobile leaflets. In mitral stenosis, the loud Firestar sound is due to the thickened but mobile leaflets. 2. The presystolic gradient between LA and LB prevents preclosure of the mitral leaflets. The presystolic gradient between LA and LV prevents preclosure of the mitral leaflets but kept wide open at end diastole. Delayed mitral valve closure at a higher LV pressure at a time when there is a more rapid rise of LV pressure increases the velocity of the valve closure. So, mitral stenosis, there is loud Firestar sound, it is due to the thickened but mobile leaflets. Second, the presystolic gradient between LA and LV prevents preclosure of the mitral leaflets but kept wide open at end diastole. Delayed MB closure at a higher LB pressure at a time when there is a more rapid rise of LV pressure increases the velocity of the valve closure. Left atrial myxoma. Here similar mechanism for booming Firestar sound as that of mitral stenosis. Exercise. Loud Firestar sound is due to tachycardia induced shortened PR interval, increased myocardial contractility due to trap phenomenon and due to the wide open valve as diastole is shortened, and increased flow across the AV valve. Hyperkinetic circulatory status. This accentuates Firestar sound due to increased flow across the atrioventricular valve and tachycardia. Hollow systolic mitral valve prolapse. Hollow systolic mitral valve prolapse, non-rheumatic MR. Loud Firestar sound is due to increased amplitude of leaflet excursion, may be due to the summation of normal M1 and an early non-ejection click of valvular prolapse. Loud T1 occurs in tricuspid stenosis, similar mechanism in mitral stenosis. ASD due to increased tricuspid flow secondary to the left right shunt at the atrial level. Anomalous pulmonary venous connection due to increased tricuspid flow. Here the diagram shows evaluation of Firestar sound. Firestar sound evaluation. Here the diagram shows Firestar sound evaluation. Firestar sound, upper left corner shows loud Firestar sound in case of mitral stenosis, left atrial myxoma and mitral valve prolapse. So, loud Firestar sound occurs in mitral stenosis, LA myxoma, mitral valve prolapse and hyperkinetic status and exercise. Diminished Firestar sound occurs in severe MR, severe AR, calcified MS. LV aneurysm, acute myocardial infarction, cardiomyopathy, left bundle branch block. Variable Firestar sound occurs in atrial fibrillation, atrial flutter with varying block, atrial tachycardia with varying block, ventricular tachycardia with AV dissociation. So, variable Firestar sound occurs in atrial fibrillation, atrial flutter with varying block, atrial tachycardia with varying block, ventricular tachycardia with AV dissociation and complete heart block with AV dissociation, MOBIS type 1 with AV dissociation. Now, splitting of Firestar sound. Wide splitting of Firestar sound occurs in case of right bundle branch block, LV pacing or ectopics. Epstein's anomaly, RA myxoma. So wide splitting of Firestar sound occurs in right bundle branch block, LB pacing, ectopics, Epstein anomaly, RA myxoma. Reverse splitting of Firestar sound occurs in RB pacing, ectopics, LA myxoma, and significant MS. Now, what are the causes of decreased intensity of Firestar sound? Now, we will discuss about the mechanism of decreased intensity of Firestar sound. It occurs in severe mitral regurgitation. Diminished Firestar sound is due to diminished mobility of the leaflets as a result of fibrosis and shortening. Diminished mobility of the leaflets as a result of fibrosis and shortening. Failure of the leaflets to close and loss of isovolumic contraction. Myocardial depression that contributes in secondary MR due to ischemia. Flail mitral leaflet, MVP with middle or late systolic prolapse usually has normal Firestar sound, while MVP patients with flail leaflet have a soft Firestar sound. Severe aortic regurgitation. Attenuated Firestar sound is due to premature closure of normal mitral valve. Premature closure of normal mitral valve due to marked increase in end diastolic pressure as a result of volume overload as seen in acute severe AR. Loss of isovolumic contraction as in chronic severe AR. Ventricular aneurysm results in soft Firestar sound due to loss of isovolumic contraction and decreased myocardial contractility. Acute myocardial infarction Firestar sound is muffled because of diminished ventricular contractility, mitral regurgitation, ventricular aneurysm, and left bundle branch block. Cardiomyopathy. Soft Firestar sound is due to decreased myocardial contractility, MR, TR, and LBBB. Myocarditis attenuates Firestar sound because of the diminished myocardial contractility. Calcified MS. Attenuated Firestar sound is due to immobility of the mitral valve. LBBB. M1 is delayed and decreased in intensity due to delay in the onset of LB contraction. Decreased LB contractility, presence of non-compliant LB facilitates atriogenic preclosure of the mitral valve, presence of concomitant first degree heart block. It is likely that more than one mechanism is operative in most of the patients with LBBB. At times, there could be a reversal of the sequence of Firestar sound, T1 followed by M1. Now, the variable intensity of Firestar sound. Variation in the intensity of Firestar sound occurs because of variation in the PR intervals and varying force of ventricular contraction. Loud Firestar sound occurs at short PR intervals, while softer Firestar sound occurs at longer intervals when the valve leaflets have partially closed. Variable Firestar sound occurs in atrial fibrillation, complete heart block with AV dissociation, Movies type 1 heart block with AV dissociation, ventricular tachycardia with AV dissociation, atrial flutter with varying block, and atrial tachycardia with varying block. Now intensity, now this table shows the intensity of Firestar sound. Increased loud Firestar sound occurs in mitral stenosis, LA myxoma, holosystolic mitral valve prolapse, non-pneumatic cause, exercise, hyperkinetic circulatory status, loud T1 intracuspid stenosis, atrial septal defect, anomalous pulmonary venous connection. Decreased diminished S1 occurs due to severe mitral regurgitation, flail mitral leaflet, middle or late systolic prolapse, severe aortic regurgitation, ventricular aneurysm, acute myocardial infarction, cardiomyopathy, myocarditis, calcified mitral stenosis, left bundle branch block. Variable Firestar sound occurs in atrial fibrillation, complete heart block with AV dissociation, Movies type 1 heart block with AV dissociation, ventricular tachycardia with AV dissociation, atrial tachycardia with varying block. Now abnormal wide split of Firestar sound. Abnormal wide split of Firestar sound. Split of Firestar sound into M1 and T1 is normally not audible as two components are synchronous or narrowly split 0.02 to 0.03 second, but may be audible in 40% of the normal individuals when the wave split is more wide, more than 0.03 second or 30 millisecond. However, it is readily recordable with a phonocardiogram. The split of Firestar sound is best detected at the lower left sternal border with firm pressure on the diaphragm of the stethoscope. The split of Firestar sound is best detected at the lower left sternal border. At the lower left sternal border with firm pressure on the diaphragm of the stethoscope. Abnormal wide split with normal sequence, that is M1 followed by T1, occurs because of delayed tricuspid component, which is due to electrical delays, delayed contraction of the RV, as in complete RVBB, proximal type, LV ectopics, LV pacing, and idioventricular rhythms originating from LV. Mechanical delays, as in Epstein anomaly, sail sound due to delayed activation and increased RA pressure, and sometimes in TS and right atrial myxoma due to increased RA pressure. Reverse splitting of Firestar sound T1 followed by M1 because of delayed mitral component, which is due to electrical delays, delayed contraction of LV, as in RV pacing, RV ectopics, idioventricular rhythm originating from the RV, mechanical delays due to increased LA pressure. Reverse splitting may also be present in significant MS and left atrial myxoma. Thank you.